I'll start. Good morning, respected faculty and my dear colleagues. I'm Dr. Sanketh from the Department of General Surgery, Unit 1. I'm here to present my case study for the clinical grand round. I present to you a case of 36-year-old female who presented in emergency with abdominal pain and vomiting for the past 2 days. She also complains of abdominal distension since the past 2 days. History of presenting illness. Patient had sudden onset pain which was severe and continuous, localized to the central abdomen. It was also associated with a few episodes of vomiting which contained food particles which non-viscous and non-bloody. She also gives a history of non-passage of flatus and feces for the past 2 days. Interestingly, she also gives a history of evening rise of temperature and non-productive cough since the past 3 months. There is no other symptoms associated with any other system. The patient received ATT for pulmonary tuberculosis for 3 months. She had a left humerus injury which was managed surgically a decade back. Personal history was not much contributory. She was P3L3 and her last period was 2 days before she was admitted. Initially, on examination of the patient, she was found to be in shock with mild pallor. Interestingly, although she was in shock, her Apache 2 score was less than 10 and she had a BMI of 17.8 kg per meter square. On abdominal examination, apart from the abdominal distension, there was nothing significant on inspection. On palpation, there was diffuse tenderness and guarding. On percussion, liver dullness was obliterated. On auscultation, the bowel sounds were absent. The rest of the examination was unremarkable. However, there was rectal ballooning on BRE, which is an ominous sign indicating that the acute abdomen was prolonged. Systems review was unremarkable. Patient was in shock with acute abdominal pain. Patient was in shock with acute abdominal pain, distended abdomen, diffuse tenderness, guarding, obliteration of liver dullness, absent bowel sounds, and rectal ballooning. All this pointed towards a clinical diagnosis of perforation peritonitis. Management of shock was started with bolus of crystalloids and antibiotics. Nasogastric tube was inserted and aspiration was done. Initially, after Foley's insertion, around 400 ml of urine was drained, followed by 30 ml per hour. Vitals were monitored continuously. On initial investigations, the total count was on the lower end, indicating immunosuppression, which was also corroborated with low platelet count. The patient also had a low albumin. The other investigations were unremarkable. Although we made a clinical diagnosis of perforation peritonitis, she did not show any evidence of free gas under the diaphragm. The abdominal X-ray indicated signs of intestinal obstruction, which was confusing. Another interesting thing was she was diagnosed with pulmonary tuberculosis, but the lung fields did not show any active lesions or any scarring of previous TB. This can be explained by the ATT intake which was started 3 months back. Since this was not corroborated with our clinical findings, we went ahead with the CT scan of the abdomen. A CT scan was done which showed pneumoperitoneum and ascites, 2 perforations in the distal ileal loops without any evidence of transition zone, narrowing or stricture. Because of pneumoperitoneum with ascites which showed leak of contrast, we took her up for surgery. Intraoperative findings. A lot of time was needed for adhesiolysis. There was foul-smelling enteric content. 2 perforations in the terminal ileum were seen. Although the mesentery was thickened, it did not show any fat encroachment onto the bowel and no skip lesions. Lymph nodes were palpable but subcentric, not fleshy. There was no evidence of caseation or calcification was seen. Rest of the bowel was unremarkable. Procedure. We did a loop ileostomy, exteriorizing both the perforation as the patient was sick. Peritoneal lavage was given and 2 drains were put. Facial closure was done with skin and subcutaneous tissue kept open for delayed primary healing. The image to the right, this was how the abdominal closure was done. Apart from the fascia, the covering of the skin and subcutaneous tissue was left open. The one on the right is an ileostomy with the stoma bag in situ. She was extubated postoperatively and intensive management was done in the postoperative period. Looking at the intra-abdominal condition during surgery, she was shifted to high-end antibiotics like meropenem and metronidazole. Postoperative progress. The stoma started functioning on the 2nd day of surgery and she was allowed orally, although supplemental IV fluids and antibiotics were continued. All the tubes were removed on POD2. However, her platelets were quite low and we took a medicine and doctor's opinion and they advised us to start the patient on oral ATT. Unfortunately, on day 7, she had a midline partial facial dehiscence which was managed by regular dressing and strapping. Beginning of second week, she had developed recurrent vomiting for which she was kept NPO and was resuscitated with fluids and total parenteral nutrition. When vomiting was persistent, DOTS consultation was taken again and second line ATT was started. However, her bilious vomiting did not decrease with medical management even after starting ATT. So gastromedicine opinion was taken and upper GI endoscopy was sought. Upper GI endoscopy showed that there was edematous mucosa and narrowing of D3 and the scope could not be negotiable. Based on the above upper GI findings, the patient was planned for CECT whole abdomen, which showed that the D1, D2, D3 were distended with transition seen at the D3, D4 junction. There was compression of D3 between SMA and abdominal aorta. Distally, the D4 and jejunal loops were collapsed. The aortomecentric angle was 16.5 degrees and the aortomecentric distance was 16.3 degrees. All these signs indicated suggestive of Wilkie syndrome. In the image to the left, we see that the aortomecentric distance is 6.3 mm. The normal aortomecentric distance is 10 to 28 mm. This is the aortomecentric distance, which was 6.3 mm. The normal aortomecentric distance is 10 to 28 mm. And this was the aortomecentric angle, which was 16.5 degrees. And we can see the duodenum here compressed between the aorta and the SMA. And here we can see the duodenum, which is dilated. Following the CT, it was diagnosed as a case of SMS syndrome. We could not operate her as it was the second week of surgery and she was very sick. She had an ileostomy, so we decided for medical management. After 3 days of TPN, she had mild jaundice and deranged LFT, due to which the TPN had to be stopped. More alarmingly, in the beginning of the third week, she started developing recurrent fevers with a total leukocyte count of 95,000. She was immediately started on vasopressor support and shifted to the HDO in view of hypotension and was started on high-end antibiotics. Because of the respiratory distress, USG chest was done, which showed bilateral pleural effusion, which was tagged by the IR team. By the end of third week, we planned an NG tube, which was placed by the IR team, and enteral freeze was started. Surprisingly, the histopathology of the intestinal segment showed areas of inflammatory infiltrate with candida colonies, and fungal culture of the peritoneal fluid, which was sent, was positive for candida. Infectious disease consultation was taken, and the patient was started on fluconazole. The patient responded and NORAD support was tapered off and the fever episode had subsided. From POD 26 to 36, the hospital course was uneventful. She improved and had gained 2 kgs of weight from her initial weighted presentation, orally accepting liquids, soft diet, and the condition was stable. And later on POD 36, the patient was discharged at her request after removing the NG tube. The patient was referred to DOTS for continuation of ATT. On the right hand side, we can see the wound which is healthy at discharge. SMA syndrome. SMA syndrome occurs due to nutcracker effect upon D3 by abdominal aorta and SMA. It presents with vomiting without abdominal distension, which usually occurs in adults with rapid weight loss. It might be congenital. The diagnosis of choice is CT, where aortomecentric angle of less than 20 and SMA distance is less than 8 mm. Ultrasound is also useful in certain cases. Non-operative management usually involves nursing the patient in the left lateral position, which decreases the tension on the mesentery and increases the angle, helping with the symptoms. Gastric decompression is done by placing the NG tube. The patient is resuscitated with IV fluids and correction of electro abnormality is usually done. Enteral nutrition is usually supported, but in some patients might require parenteral nutrition, in whom the enteral nutrition cannot be provided. The various surgeries that are present for SMA syndrome. The initial surgeries that were done in the previous days included Strong syndrome. Gastrojejunectomy is not usually done these days, and the one with promising results is duodenojejunectomy. Her overall problems and her solutions. The patient had a perforation with sepsis, which was managed by surgery and antibiotics. High output ileostomy, for which distal refeeding was done. For partial dehiscence of laparotomy wound, We did regular dressing and strapping. She had pulmonary TB but not tolerant to oral ATT, so she was switched to second-line injectables. In view of her NPO status, she was started on TPN, and which caused jaundice, for which NJ tube was placed later on by the IR team. In view of intractable vomiting, upper GI endoscopy was done, which showed dilated D3, followed which CCD whole abdomen was done, which was suggestive of SMA syndrome, which was managed non-operatively. Although the best management for SMA syndrome was surgical, we could not do it due to the patient's condition. NJ was placed and patient responded. In view of respiratory distress, ultrasound chest was done, which showed pleural effusion, which was stabbed. We were lucky we could diagnose the cause of the fever and hypotension, as both the fungal culture and histopathology was suggestive of fungal infection, which was non-responsive to normal standard antibiotics. We are thankful to the hospital administration and the medical superintendent for making her expenses poor-free. We are thankful that we could successfully manage her and bring her out of a crisis due to multidisciplinary team effort by the surgery department, anesthesia department, gastroenterology, medicine, intensive care, ID, radiology, especially the interventional radiology team, pathology, microbiology, pulmonary medicine, dietitian, and the hospital administration. The 4 more learning points from this case were to provide the best care for a high output ileostomy in a resource limiting setting. Refeeding enteroclasses is a viable option. In patients with intractable bilious vomiting without abdominal distension, SMA syndrome should be considered. Fever not responding to usual antibiotics, fungal septicemia should be ruled out. TPN should be replaced with enteral feeds as soon as possible due to its complications and the complication associated with central line. Thank you.